So hello everyone, and today we are going to read a very important core topic of pediatric nephrology, that is nephrotic syndrome. This is a very important topic for MBBS graduate as well as for PG students, as well as whoever is preparing for PG, or even if they are pursuing PG in pediatrics. Nephrotic syndrome is a core topic. Okay, so let's read it. Nephrotic syndrome has three features. See, first is heavy proteinuria. Okay, and oh god, one second. See, so first is heavy proteinuria, which is characterized by more than 1 gram per meter square. This is for per day, or more than 40 mg per meter square per hour. Proteinuria or spot UPUC. UPUC is urine protein to creatinine ratio, which is more than 2 mg per mg. Okay, then second is hypoalbuminemia, that is albumin less than 3 gram per deciliter, and edema. So these three things are the three criteria for nephrotic syndrome. Proteinuria, how much, you have to remember this. Hypoalbuminemia, and third is edema. See, you can see the edema. This is the periorbital edema. Okay, now comes the important definitions that you need to know before we dive into the topic of nephrotic syndrome. First is nephrotic range proteinuria. What you will say as nephrotic range proteinuria is if urine protein more than +3 by dipstick, or UPUC is more than 2, or protein excretion is more than 40 mg per meter square per hour. That we have already seen. Then comes remission. When you will say it has remission means kind of cured. Okay, so in that case UPUC should be nil or trace for 3 consecutive days in the early morning specimen, and UPUC is less than 0.2 mg per mg, proteinuria less than 4. Proteinuria in nephrotic syndrome was more than 40 mg per meter square per hour. For remission it should be less than 4 mg per meter square per hour. Then relapse usually happens post upper respiratory tract infections or post immunization or minor infections. Okay, then it can lead to relapse, and in that case urine protein more than +3 again for 3 morning specimens, UPUC more than 2 mg per mg, and proteinuria more than 40 mg per meter square per hour. That means relapse. Okay, next comes frequent relapse. If 2 or more relapse occur in the initial 6 months, or more than 4 relapse in 12 months, that is frequent relapse. So in the initial 6 months, if 2 or more relapse, or more than 4 in the total 12 months, that means frequently it is relapsing, and in that case we might need to think of an alternate treatment. Okay, next comes steroid dependence. What is steroid dependence? If 2 relapse occur during steroid therapy or within 14 days of discontinuation. When you discontinue, again that thing happens, that proteinuria and all that show up. So that means steroid dependence is there. Then comes steroid resistance. If absence of remission despite prednisolone, if you give prednisolone at the rate 2 mg per kg per day for 6 weeks and still that the remission did not take place, that means there is no still, like you are seeing proteinuria, you are seeing that edema and all that, that means there is steroid resistance. Next comes pathology. So what is the pathology of nephrotic syndrome? So first is minimal change disease. Okay, minimal change disease is the most common we have different types. Okay, so minimal change disease is the most common thing that we see in children of 2 to 6 years. Okay, in minimal change disease, what we will see in light microscopy are insignificant glomerular changes. There won't be that much changes, and in electron microscopy we will see effacement of the podocyte processes. Okay, and the GFR barrier gets altered. What happens in nephrotic syndrome is the glomerular filtration barrier, which is formed by podocyte slit, diaphragm, basement membrane, and the capillary endothelium. See, I will show you. Okay, this is the capillary endothelium, this is the basement membrane, and this is the slit diaphragm. All these things are forming the GFR barrier. This gets altered, and permeability this gets altered, leading to increased permeability, or we can say not increased, I think decreased. Yes, GFR will be decreased. Altered permeability leading to decreased GFR. Okay, next thing what happens is some theories also suggest that the cell mediated immunity gets altered, leading to some T helper 2 stimulation, which will stimulate T lymphocytes, which will lead to release of some circulating factors, and those circulating factors lead to increased glomerular permeability. Okay, that permeability is increased, that is altered basically. I shouldn't say permeability, increased permeability, I think it gets altered. Okay, post infection this happens. Then comes what are the circulating factors that we are talking about, which are altering this glomerular permeability. Interleukin 13, angiopoietin like 4, CD80, and this urokinase plasminogen activator, vascular endothelial growth factor, and hemopexins. Then comes crosstalk between B and T helper cells. Some theories also suggest that some B B cells are also involved in this pathogenesis. Then actin dynamics, like some motility this permeability is getting altered, no? So some theories say that actin motility and that cytoskeleton, something like some changes happen in that which lead to altered permeability. Okay. Then next comes steroid sensitive nephrotic syndrome, which is the one we are talking about. That means that is steroid sensitive. You give prednisolone and it responds. Okay. And most common in this is minimal change disease we are talking about, which happens in 2 to 6 years of age group with edema, which starts first periorbital around the eyes, then goes to legs and abdomen. Okay. So this is minimal change disease. But if you see, instead of along with edema, if you see hypertension or altered renal function or persistent hematuria, that is persistent microscopic hematuria, renal function is altered and raised BP, then that means glomerular lesions are present. That is not minimal changes. We'll think for FSGS or membranous nephropathy or membranoproliferative glomerulonephritis. Now, what are the initial evaluation that you will do? Obviously, you will go for urine analysis. You will look for proteinuria, red cells and cast. You will go for urea, creat, albumin and cholesterol. You will go for CBC. You will go for tuberculin tests. Tuberculin test if you suspect like TB, because these infections occur in immunocompromised people. So if a person is having TB, that child is immunocompromised and can get this nephrotic syndrome. You can also go for C3 and ASLO if you are seeing gross or persistent hematuria. This is done to rule out nephritic syndrome. Chest X-ray if you see positive tuberculin or any history of contact with the tuberculosis positive person is there. HbS you can go for if you see jaundice or raised ALT and AST, and ANA and anti-dsDNA if you suspect that the child may have lupus. Then next comes indications of renal biopsy. So when you'll go for a biopsy, see, normally nephrotic syndrome there is no need of renal biopsy, okay, just this treatment. But renal biopsy is indicated if it happens in less than 1 year or more than 16 years. Normally it happens in 2 to 6 years. If it is happening at less than 1 year or more than 16 years, renal biopsy. Gross or persistent microscopic hematuria, okay, that blood is already coming persistently. Low C3, raised BP, altered function which is not attributed to hypovolemia, kidney function is altered, and if you suspect some secondary cause. See, these are some images that I have taken from multiple sources. This is minimal change disease. Okay. Normally you will see that effacement of podocytes and everything in the electron microscopy image, but here you won't see much changes. Okay. This is the focal segmental glomerulosclerosis. You can see this hyaline thing, the hyaline thickening, FSGS. This is also FSGS. This is thick membrane. This is, you will see in membranoproliferative glomerulonephritis. Okay, this is the silver stain and this is the normal one. And here you can see membranous glomerulopathy with thick wall. See, this is the normal one, thin one. This is the thick wall. This is membranous glomerulopathy. Okay, then next comes management of steroid sensitive nephrotic syndrome. How you are going to manage? First, you will give diuretics, furosemide, 1 to 4 mg per kg per day in 2 divided doses, and you can give it alone. Okay, if diuretics you will give if edema is present. Okay, if edema is present, you need to resolve it by giving diuretics, or you can give with aldosterone antagonist, that is spironolactone, because it will lead to hypokalemia. So this will be potassium sparing, so it won't lead to hypokalemia, and you can give with spironolactone. Then second, the main treatment corticosteroids, only prednisolone and prednisone. No need of that deflazacort and all those things. Only these two work. They should be given after meals, and if you suspect GI intolerance, you can go for antacids. You should give them at the rate 60 mg per meter square or 2 mg per kg in single or divided doses for 6 weeks. So you have to give it 2 mg per kg in single dose or divided doses for 6 weeks, followed by, this was 60 mg per meter square. Now this is 40 mg per meter square, or this is in terms of body surface area. Or you can give 1.5 mg per kg. This is in terms of body weight as single morning dose on alternate day for 6 weeks. So total 6 weeks, 6 weeks. It is 12 weeks treatment you have given. Okay. This was daily. This was on alternate day. Then you should educate the parents on how to examine urine from protein. They should know. Urine dipstick, they should know. Salt restriction is not necessary except moderate to severe edema is present or hypertension is present. The food should be palatable. You should not make it non-palatable for the child. Then child won't eat. Okay, then next comes if relapse happens, which can happen after upper respiratory tract infections. In that case, you have to give prednisolone 2 mg per kg daily until protein is negative or trace for 3 consecutive days. Suppose if the child comes in follow-up and you see that again the child is having proteinuria more than like dipstick more than +3 for 3 consecutive days, you are seeing, then in that case again you have to start for like what are the 3 things you have to check, all that UPUC and all that. If you are seeing again that that proteinuria, then you have to give prednisolone 2 mg per kg daily for 3 days until you have to give it daily till you get protein negative or trace for 3 days. Okay, and then you have to taper it to 1.5 mg per kg alternate day for 4 weeks. Okay, so generally this will happen in around 5 to 6 weeks that relapse gets managed. Okay, infrequent relapse, what does infrequent relapse means? You are getting 5 to 6 weeks treatment. Okay, if relapse is happening not frequently but infrequently, if it is recurring, you have to give this treatment for each relapse. Give prednisolone 2 mg per kg daily till you get protein negative or trace for 3 consecutive days, then shift it to 1.5 mg per kg on alternate day for 4 weeks. Okay, then if frequent relapse or steroid dependence is seen, then in that case some theory suggests, or like that in the textbooks it's written, prednisolone is given at lower doses. Normally we give at 2 mg per kg, here we give at 0.5 to 0.7 mg per kg on alternate day for 9 to 24 months, means low dose steroids for longer duration. Or you can shift to levamisole, cyclophosphamide, mycophenolate mofetil, cyclosporin or tacrolimus and rituximab. So these are some other immunosuppressive agents that you can go for. Okay, next comes what are the complications that you see in nephrotic syndrome. If you are an MBBS student, you just need to know the names of complications and little bit about them. But if you are a PG aspirant or if you are currently pursuing PG, you need to know the management of this. Like you need to know in detail about each complication. Okay, so first is edema. If you see that edema is not improving, okay, and that edema is not associated with hypovolemia. See what happens in nephrotic syndrome, sometimes we give diuretics, and if we give diuretics so much aggressively, or the child is also having vomiting and dehydration, the child can go into hypovolemia. And in that case also edema, like if the child is having hypovolemia, how will you identify? Child will be having tachycardia, feeble pulse, tachycardia, feeble pulse, low BP, cool peripheries and raised hematocrit. In that case you have to give normal saline like bolus of 15 to 20 ml per kg over 20 minutes. You have to give quickly. Or you can also give albumin 5% at the rate 10 to 15 ml per kg. If it is 20% albumin, at the rate 0.5 to 1 gram per kg. If you're an MBBS student, no need to remember doses, but if you are a PG, if you are doing PG, then you need to remember the doses. Okay, this is done so that the intravascular volume rises. Okay, if hypovolemia is not there, still edema is not subsiding, first of all give oral furosemide at rate 1 to 3 mg per kg per day. If no response, add spironolactone at 2 to 4 mg per kg per day. It will also prevent hypokalemia because it is potassium sparing diuretic. Okay, this is potassium sparing. If no response, increase to furosemide dose to 4 to 6 mg per kg per day. That is the max dose. You started from 1 to 3, you increase to 4 to 6. Now you can't increase it. So now you have to add hydrochlorothiazide. These are the thiazide diuretics or metolazone. This is at 1 to 2 mg per kg per day. This is at 0.1 to 0.3 mg per kg per day. If still no response, give IV furosemide bolus at rate 1 to 3 mg per kg per dose, or infusion at rate 0.1 to 1 mg per kg per hour. If no response, you have to give 20% albumin at 1 gram per kg IV followed by IV furosemide. Okay. The next comes infection. See, these are immunocompromised child, and if they have got nephrotic syndrome, they can it can obviously lead to peritonitis, cellulitis, and even varicella. See, varicella in these children will be very life threatening. So in that case, you have to give oral acyclovir for 7 days, or you can also give immunoglobulin varicella zoster within 96 hours, or acyclovir oral for 7 days. You have to give them because they are too much immunocompromised and varicella in them can be life threatening. Next, if you are seeing hypertension which is persistent and refractory to control of edema, you can give ACE inhibitors, enalapril 0.3 to 0.6 mg per kg per day in 2 divided doses, or ramipril, or calcium channel blocker or adrenergic blockers, but starting is enalapril. Okay, but this is hypertension if it is persistent, not in the starting. Then dyslipidemia. In steroid resistant nephrotic syndrome, and in these cases, if dyslipidemia is present, if total cholesterol is more than 200 or LDL is more than 130 for 3 to 6 months, you can start statins, HMG CoA reductase inhibitors, atorvastatin at 10 to 20 mg daily for if the child is more than 6 years. Okay, then this nephrotic syndrome can also lead to thrombosis. Why? Because the intravascular volume is less, because of diarrhea or increased diuretic use, and proteinuria is causing loss of antithrombin 3 or immobilization or indwelling catheters. It can all lead to thrombosis that can be identified by Doppler or MRI, and in that case give heparin or low molecular weight heparin and then shift to oral anticoagulants for 4 to 6 months. Then comes vaccination. See, in nephrotic syndrome, they are already immunocompromised, and you are giving prednisolone, which is an immunosuppressant. So you have to defer the live vaccines. Okay, you can't give live vaccines. OPV, varicella are deferred till the child is off immunosuppressive agents for 4 weeks. Till 4 weeks. Okay, like 4 weeks gap should be there. But you have to give pneumococcal vaccine in them. If less than 2 years, give 0.5 ml IM. If more than 2 years, first give conjugate vaccine, pneumococcal conjugate vaccine, and with the gap of 2 months, give PPV23 polysaccharide vaccine. If increased relapse, then you can also give a booster after 5 years, PPV23. See, because these children, if they get URTI, again they will get relapse. So you have to give pneumococcal vaccine. If the child is less than 2 years, give 0.5 ml IM. If the child is more than 2 years, give PCV conjugate vaccine. Keep a gap of 2 months, give PPV23. And if increased relapse, then at a gap of 5 years, you can give booster of PPV23. Okay, and you can also give 2 doses of varicella vaccine, and that should be 4 weeks apart when the child is in remission or off immunosuppressive agents for 4 weeks. You can also give IPV, that is injectable polio vaccine. Then comes nutrition. Obviously, you have to advise balanced diet. If edema is present, then salt restriction. Protein should be at the rate 2 to 2.5 gram per kg per day should be given. Physical activity advised. Give calcium and vitamin D if you have continued prednisolone for more than 3 months. Add calcium 250 to 500 mg and vitamin D 200 to 400 international units. Then comes stress dose of steroids. See, when you give higher doses steroids for more than 2 weeks, that child, if undergoes any surgery or any infection or any anesthesia later on in life, they may need, because these steroids will suppress the hypothalamo pituitary adrenal axis, so they may need steroid stress dose. IV hydrocort at the rate 2 to 4 mg per kg per day, and after that prednisolone 0.3 to 0.6 mg per kg per day if they undergo any surgery, infection or anesthesia. Then hypovolemia, we already discussed it, the most important complication because of aggressive use of diuretics, vomiting or diarrhea, which can be identified by pain abdomen, lethargy, dizziness, tachycardia, low BP, raised CRT, then low pulse, cool peripheries, blood urea to creat ratio will be more, raised hematocrit, and urine sodium less than 20, urine potassium more than 0.6. All these suggest the child is having hypovolemia. Management: give NS bolus 10 to 20 ml per kg over 20 to 30 minutes up to 2 bolus. If no response, go for 5% albumin or 20% albumin. Both the doses are different, you have to remember it. So that's all about nephrotic syndrome. I hope you understood, and okay, thank you.